We have learned about blood pressure in the previous lecture. So now we focus on an abnormal situation with blood pressure, that is hypertension. Hypertension is high blood pressure. So we will start off with a review of normal blood pressure versus pre-hypertensive, and then ultimately the actual hypertension. So normal blood pressure, you have two numbers to look at, that is systolic and diastolic. Systolic ranges from 110 to 120 millimeter mercury. Diastolic varies from 70 to 80 millimeter mercury. Now, pre-hypertension is a condition where you have a range of 121 to 139 systolic, 81 to 89 diastolic. So when you think about pre-hypertensive or hypertensive, you also have to keep in mind that a slight change in blood pressure during situations like exercise is not considered as pre-hypertensive or hypertensive. Only when it's consistently high is when you call that as hypertension or pre-hypertension. Okay, so that has to be there. When you exercise, your blood pressure does go up and then it returns back to normal. So it's not hypertension. All right, so now let's talk about hypertension. Consistently high levels, high systolic and high diastolic numbers. So you're talking about over 140 millimeter mercury systolic, 140 or above, and then 90 or above diastolic. It could be either systolic or diastolic or both that leads to hypertension. Okay, hypotension. Although we won't be spending too much time on hypotension, it's the opposite of hypertension. It's less blood pressure than normal. What is the criteria for one to be called hypertensive? That is systolic below 90 and diastolic below 60. So let's pause here and think about what are the complications of hypotension or hypertension. Hypotension is where there is less pressure, meaning there is less push for the blood to get to the tissue. The consequences, tissues are deprived of blood supply, ischemia, deprived of oxygen supply, and tissue death. So these are the consequences with hypertension. So you always have to have a certain pressure in the blood vessel to make sure that the tissues do receive their normal blood supply. Now, what about hypertension? Won't it be good if you have high blood pressure so that we can supply tissues with more blood? No. If you have too much pressure, it can harm the structures that carry this blood to the tissues. Too much force can damage the blood vessel wall, rupture the blood vessel wall over time. So those are some complications. So you really have to maintain blood pressure within the normal range. So that's the bottom line, okay? Now, let's move on to look at the different types of hypertension. One is primary or essential hypertension. That's the most common type. 95% of the patients have primary or essential hypertension. Now, the first question is, what causes this type of hypertension? We do not know that. There are a number of factors that we will go over that could be responsible for primary hypertension. So etiology, that is the cause, is hard to pinpoint. All right, secondary hypertension is where another structure is not functioning, and therefore it leads to hypertension. A good example is a kidney failure. It's not able to release enough fluid in the form of urine. So urine output is less and fluid back up in the blood, and too much blood, increased volume, increased blood pressure. We know that relationship already. So that's how you think about secondary hypertension. All right, good. So whether it is primary or secondary hypertension, the consequences are still the same. What causes hypertension? Well, if you remember, we talked about how hypertension is determined by two key factors. One is cardiac output. Two, it is the total peripheral resistance. Okay, the opposition for blood flow is what you call as total peripheral resistance. Okay, so if that is the case, we know that cardiac output, greater the cardiac output, greater the volume of blood in the body, and greater the blood pressure. Linear relationship. That's the same with total peripheral resistance, TPR. Greater the resistance, greater the blood pressure. All right. So it could be either cardiac output or total peripheral resistance, or both that lead to hypertension. Now, what makes us have more than normal cardiac output? What makes us have more than greater resistance? These were discussed in appropriate lectures. So if you have any doubts, we need to go back and look at those lectures to focus on what increases cardiac output. Well, cardiac output is regulated, or it has two components as well. One is the stroke volume, the other one is the heart rate. Increasing stroke volume or increasing heart rate would increase cardiac output. Do you recall that? Now, let's also talk about TPR. We discussed this earlier. That is the length of the vessel, the radius of the vessel, viscosity of the vessel. All these factors can affect resistance. All right. So those are some things you need to recall. Now, let's move on to the continuation of how we develop hypertension. What are some known causes of hypertension? As always, genetics does play a role. Okay, directly or indirectly, it could be the culprit. And then renin-angiotensin-aldosterone system. Let's review renin-angiotensin-aldosterone system briefly again. That is, anytime there is decreased blood pressure at the kidneys immediately release renin. Renin then converts an inactive protein, angiotensinogen, to angiotensin 1. And this ultimately gets converted to angiotensin 2. Angiotensin 2 has two key roles. One is to turn on the secretion of aldosterone. Two, it causes vasoconstriction. All right, so this is just a quick summary of renin-angiotensin-aldosterone pathway. What if renin-angiotensin-aldosterone pathway is consistently activated? That would increase blood pressure non-stop, and that would lead to hypertension. Okay, a sympathetic overactivity. We know that sympathetic activation causes an increase in heart rate, increase in stroke volume, so overall increase in cardiac output. It also increases vasoconstriction. What that means is increase in total peripheral resistance. So sympathetic overactivity could lead to the increased blood pressure consistently, and that leads to hypertension. last but not the least, in fact, there is so much focus on this last one in the list, that is endothelial dysfunction. Endothelial dysfunction is where we need to recall endothelium. Endothelium is the innermost lining of the blood vessel wall. It is prone to a lot of different changes in the body can influence the endothelial cells. First of all, high blood pressure can harm the endothelial lining. Okay, if there is too much fat in the blood, that could lead to damage in endothelium. There are many other culprits. Inflammation is another one that could harm endothelium. So it has been the focus of researchers these days. Endothelial dysfunction is because of a long list of things: inflammation, obesity, smoking, hypertension, and so on and so on. So we will spend some time talking about these factors in a little bit more detail in the next set of slides. Genetics first. Okay, direct role of a specific gene on hypertension is not the case. Okay, it could be a gene that is affecting sodium reabsorption. Okay, so one gene that's abnormal may stimulate the reabsorption of sodium in greater amounts than normal. What does that do? It would retain more water. That would lead to hypertension. So this is an indirect relationship. Now, yet another place where they could be involved is in the receptor level. Angiotensin receptor could be abnormal. Okay, binding of angiotensin to the receptor could lead to vasoconstriction in greater than normal capacity. Okay, so these are some genetic implications that could be connected to hypertension. So hypertension is not because of a gene that triggers high blood pressure just like that, but it is via salt absorption, via another receptor upregulation, etc. All right. So, well, polymorphism is many different forms, many different effects of the genes at the receptor level is what we are thinking here. All right, so we talked about renin-angiotensin aldosterone pathway just a few seconds ago. So we will talk about how this could be abnormal, leading to high blood pressure. Okay, renal injury. All right, so kidney damage. There is less salt being removed, okay, decreased renal sodium excretion. So you're not able to get rid of enough salt. That means you're retaining more. When you retain more sodium, you would draw more water with it. Okay, so that is the solute drawing water by osmosis. So keeping more salt, keeping more water would lead to greater than normal blood pressure. All right, so that is one way renin-angiotensin aldosterone pathway could be the culprit. Now let's focus on the sympathetic overstimulation, overactivity of the sympathetic system. If there is overactivity of the sympathetic system, it would increase heart rate. Increased heart rate, increased cardiac output, increased hypertension. All right, that's one equation. It also increases total peripheral resistance, TPR. That would increase hypertension. greater the resistance, greater the blood pressure. We know this equation. Okay, so sympathetic activation could lead to vascular remodeling. Basically what it is the vasoconstriction would narrow the vessel. Okay, there may be vasospasm triggered by sympathetic activation. Vasospasm is vasoconstriction on and off and on and off. So that kind of situation, basically TPR and vascular remodeling are somewhat connected. Agree? Increased TPR, total peripheral resistance, is because of the narrowing of the vessel through vasoconstriction and vasospasm. All right. Procoagulant properties. This is another thing about overactivation of the sympathetic system. It may activate certain factors, blood clotting factors, and trigger this abnormal blood clotting process. We have gone over blood clotting to understand what thrombosis means. Thrombosis is unwanted blood clot being formed. So overactivation of the sympathetic system could increase TPR, could increase blood volume, all these increase blood pressure, and then it could also cause thrombosis. What's the consequence of thrombosis? Well, it occludes the vessel, and that again increases resistance and therefore increased blood pressure. All right, insulin resistance. That's another situation with overactivity of the sympathetic system. Insulin resistance is where the cells do not respond to circulating insulin. Okay, we will spend more time talking about insulin resistance later, but then insulin resistance makes you keep more glucose in the blood. When you have more glucose in the blood, you tend to retain more water in the blood. What that means is increased blood volume, increased blood pressure. Again, sympathetic overactivation could again lead to endothelial dysfunction. So note how endothelial dysfunction could be due to many factors. Okay, it can be inflammation, it could be overactivation of the sympathetic system. So how does that affect, how does that trigger blood pressure? Decreased production of vasodilators. Nitric oxide is a good example of a vasodilator. Even there is overactivation of sympathetic system, it's causing vasoconstriction and endothelial dysfunction. Endothelial cells make the vasodilators, and without the endothelial functioning, we would be producing less vasodilators. All right, so when there are less vasodilators, there is more vasoconstriction. Inflammation is the injury to the blood vessel wall. Over activation of the sympathetic system can cause inflammation. Inflammatory agents are notorious. Just know that. Cytokines released by this process, inflammation, are the culprits in many different ways. So before we get to the inflammation and its effect, let's talk about the summary chart here. Basically, it's repeating the same thing we talked about: sympathetic activation, how it triggers hypertension. Okay, so overactivity of the sympathetic system, increasing heart rate, increasing peripheral resistance, triggers hypertension. Insulin resistance could cause endothelial dysfunction. Insulin resistance could directly cause hypertension by keeping more glucose, more water in the blood. That is not shown here, however. Okay. Now, vascular remodeling. We talked about that vasoconstriction, vasospasm could lead to narrowing of the vessels, causing hypertension, triggering procoagulant factors, now blood clot, and that could occlude the vessel and narrow the vessel, lead to hypertension. Endothelial dysfunction could narrow the vessel and cause hypertension. So they're all somewhat interconnected, if you notice that. Okay, So endothelial dysfunction is elaborated in this slide. So we will see how that triggers hypertension. Damage to endothelial lining. This is the blood vessel wall being damaged. Now the wall matrix is the tunica media, tunica interna, all of those would have a different morphology, different design than normal. Okay, activation of platelets. Why? The vessel damage exposes collagen fibers. We know this from our blood clotting discussion. So that triggers blood clotting, and that's what you call as thrombosis. Inflammatory response. Anytime there is damage, injury, there is inflammation. Okay, inflammation is through the release of inflammatory agents and the arrival of phagocytic cells. Correct? More blood arrives, more phagocytes arrive, they are activated, they release chemicals, the site of injury releases chemicals. So you're looking at a variety of agents being around to turn on the vasoconstriction. Now, let's take a look. Endothelial cell proliferation and smooth muscle hypertrophy. These are some changes associated with injury. Okay, proliferation is endothelial cell number is increasing. Smooth muscle fibers, their numbers won't increase, but their size would increase. Okay, so now the vessel lumen is the space within the blood vessel that is taken over by all these modifications. So as you add more cells, as you make the blood vessel, the smooth muscle fiber expand, it takes up the space within the blood vessel. And that would occlude the vessel partially or fully. All right, leakage of plasma. Remember leakage of plasma, that is because of vasodilation related to inflammation. So more blood arriving, leakage, increased vascular permeability is what I should say, and that leads to local edema, swelling. All right, repair process begins with inflammation. Okay, the white blood cells that are in the area release agents to fix this situation and trigger repair process, and now that adds to more thickness. How? This repair process adds more fibers into the area, and that leads to more occlusion. That leads to ischemia of the tissues. We are only focusing on the key organs here, such as brain, heart, kidneys, but this can happen to any other tissue. All right. If it is pulmonary hypertension, it's the lung tissue that's going through hypertension, then there is a backup of blood into the right ventricle. Remember that lungs receive blood from the right ventricle. This is pulmonary artery connecting right ventricle to the lungs. Whenever there is too much pressure, blood cannot flow into the lungs, and therefore it sits in the right ventricle. What happens? Right ventricular wall thickens. Okay, there the myocardial remodeling may be the case. Then the wall gets thicker. So these are all changes that you expect with endothelial dysfunction. Quite a bit of detail here, a lot of cellular mechanisms associated with the repair process, chemical agents, the proliferation of endothelial cells, hypertrophy of the smooth muscle. All these are factors that interfere with the blood flow, correct? Occlusion of the vessel, and thrombosis, and hypertension. Now we will get into these chemical agents that are associated with inflammation and how they play a role in hypertension. Inflammatory mediators, a number of chemical agents. We are going to spell out some chemical agents here that are key. Tumor necrosis factor, TNF alpha, okay, and interleukin 6, IL-6, are the two key inflammatory cytokines. They then can trigger the release of C-reactive protein, CRP. We talked about CRP earlier with coronary artery disease. So that is the same agent. This is an inflammatory agent that could be released during inflammation. This could be via the other inflammatory cytokines like TNF-alpha and interleukin-6. Okay, C-reactive protein is made in the liver. It could be released in response to TNF-alpha, interleukin-6. It could also be released in response to other factors released by adipocytes, smoking, etc. So again, C-reactive protein has become a very interesting molecule to focus on, because inflammation is now involved in all the major diseases that we know of, and then C-reactive protein is the mediator inflammation user, so there is a lot of study going on. Okay, if you think about obesity, then you have more adipocytes, those are fat cells, therefore they would trigger the release of more CRP, C-reactive protein. Okay, smoking is bad. Why? Look at this. This triggers the release of C-reactive protein. What does the C-reactive protein do? Well, triggers hypertension. There you go. So inflammation, C-reactive protein, hypertension. How is that? That's a good equation, isn't it? Here, a quick word on the concentrations of C-reactive protein in the body. Less than 1 milligram per liter, low risk for developing hypertension. 1 to 3 milligram per liter, average risk. Over 3 milligram per liter, high risk for hypertension. Okay, so now let's go back to tumor necrosis factor alpha, TNF-alpha. Okay, it's again linked to hypertension and insulin resistance. How does that bring about hypertension independent of C-reactive protein is what we are looking at here. It increases the secretion of endothelin-1. Please note that endothelin-1 is a vasoconstrictor. Okay, so TNF-alpha can do two things. One is to trigger the production of C-reactive protein, trigger the release of endothelin-1, which causes vasoconstriction, and the production of angiotensinogen. What does angiotensinogen do? In the presence of renin, it can get converted into angiotensin-1 and ultimately angiotensin-2, which causes vasoconstriction. Sorry. IL-6 can be independently involved in triggering hypertension. How? It could trigger sympathetic activation. We already know how bad overactivity of sympathetic system can be for hypertension. Again, it uses angiotensinogen, angiotensin-2 pathways to cause hypertension. Now we talk about environmental factors. We talked about inflammation, endothelial dysfunction, overactivity of the sympathetic system, genetic factors. Now, other factors. Stress is related to hypertension. Stress could stimulate what? Sympathetic system. Okay, sympathetic overactivation, we already know, is directly related to hypertension. All right, obesity is linked to hypertension. We know that adipocytes release nasty agents. These nasty agents can in turn trigger hypertension. Smoking, we have come across smoking a couple of times now. C-reactive protein is one way, inflammation is another way. Inflammation has a bunch of chemical reagents we talked about earlier, and therefore smoking is the trigger for hypertension. Lack of physical activity. So again, obesity could be because of lack of physical activity. Heavy salt consumption, this is debatable. Okay, in a normal person, it may not be, but in an obese person, it could be. So that is where this has to be spelled out depending upon who you're talking to. Okay, frequent high alcohol intake. Too much alcohol is also associated with the fatty liver. Fatty liver is increased fatty acid release and the chemicals that are released, and endothelial dysfunction and hypertension. this is the last slide where we look at the signs and symptoms of hypertension. Okay, well, if a person is hypertensive, how do we know? There may be no sign. It may be so silent. Okay. My brother did not know that he had hypertension. He was having headaches and he was treating headaches with Tylenol. One day he was driving his motorbike and he collapsed and had a blood clot in his brain, and taken to emergency room, and they had to remove that, and had a stroke and still recovering from it. So that's a good example of what hypertension could be like. Absolutely no symptoms in some cases. All right. And sometimes you may have headache, as my brother did. Palpitations, if it's associated with increased heart rate. Exertional dyspnea. So when you're exercising, etc., you may have difficulty breathing. That may tell you that there may be something going on. Okay. Long-term implications, as you know, blood vessel damage, blood vessel rupture, stroke, coronary artery disease, atherosclerosis, a long list of things. Okay. So this is where we stop. This is all about hypertension.